All right. Well, welcome to today's panel, the Organ Donation Dilemma, Ethics, Economics, and Life-Saving Solutions. I'm very excited to hear from the experts who will help us unpack this contentious issue. But first, I want to introduce you all to the Hopkins Business of Health Initiative, HBHI, in our webinar series. I'm Dan Polsky, the director of the Hopkins Business of Health Initiative. HBHI is Hopkins-wide. We bring together scholars from across the entire university who are working together for an accessible and trustworthy healthcare system. We want the healthcare system to deliver value and affordability to society through a focus on the role of business and incentives. And as part of this effort, we host a monthly Conversations on the Business of Health, where we bring experts together to discuss emerging issues. I want to introduce our moderator who has organized this session, Professor Mario Macis. He's professor at Johns Hopkins Carey Business School. Today's topic is connected to his focus on understanding the factors that influence people's support for markets and market-based solutions to social problems and the impact of these elements on economic and social outcomes. And with that, I'm going to turn the session over to our moderator, Mario Macis.
All right. Thank you, Dan. Thank you very much. And good afternoon, everyone. And again, welcome to today's webinar. Before we begin, I want to mention that members of the audience are welcome to submit questions in the Q&A feature of Zoom. We will be monitoring them and answering some of them live in the Q&A chat, but we will also reserve about 10 minutes at the end to take and answer your questions live. So the topic that we will be discussing today is probably one of the most difficult and contested issues in health policy, whether incentives and could help alleviate the shortage of organs for transplantation in the United States while maintaining ethical standards. There are more than 100,000 people in the US currently who are waiting for an organ transplant. About 90,000 of them are waiting for a kidney. And unfortunately, thousands die each year before one organ becomes available. And so this persistent gap between the need and the supply of organs is one reason why some have argued that we should consider policy approaches that go beyond the current system. It is illegal in the US to buy or sell organs. Yet proposals have been advanced, arguing that incentives, financial and non-financial, but the focus today will be on financial incentives, that incentives could substantially increase donation rates. Others worry that moving in that direction would raise profound ethical concerns. Our goal today is to explore these issues carefully and thoughtfully, with the help of an outstanding panel representing different perspectives on this difficult subject. And we're making the discussion as concrete as possible. So rather than purely abstract, right, we will be examining an actual proposal that is actually on the table in the form of proposed legislation before Congress. The panelists, I should mention, they have also kindly shared materials in advance, and those materials are posted on the HBHI website that's dedicated to today's conversation. Speaking of the panelists, we're really fortunate to have an extraordinary group of speakers with us today, and I'm really honored to introduce them. Alexander Capron is University Professor Emeritus at USC, where he also serves as the Scott Vice Chair Emeritus in Healthcare Law, Policy and Ethics, and Professor Emeritus of Law and Medicine. And also, he is the founding co-director of the Pacific Center for Health Policy and Ethics. He is one of the country's leading scholars in health law and bioethics, with decades of work spanning medical ethics, public health law, and health policy, including service at the World Health Organization and on the National Bioethics Advisory Commission. Gabriel Danovitch is Emeritus Professor of Medicine at the David Geffen School of Medicine at UCLA, Emeritus Medical Director of the UCLA Kidney Transplant Program. He also serves as Medical Director of Organ Operations at One Legacy and as Physician in Nephrology at the VA Greater Los Angeles. Professor Danovitch is widely recognized for his leadership in kidney transplantation and his work on transplant medicine, transplant ethics, and public policy. Kimberly Krawiec is the Charles Gregory Professor of Law at the University of Virginia. Her research focuses on taboo trades currently, or exchanges that are morally contested and sometimes legally prohibited. And in recent years, she has written extensively on incentives for organ donation, including both financial and non-financial approaches, such as kidney swaps, need chains, or non-simultaneous extended altruistic donor chains, and priority systems. And Elaine Perlman, she is president of the Coalition to Modify NOTA and executive director of Waitlist Zero. Elaine is a leading advocate for policies aimed at ending the kidney shortage, including the End Kidney Deaths Act. We'll hear about that today, and discuss that. Elaine has also been deeply involved in expanding living donation through advocacy, mentoring, and community building. Elaine is herself a living kidney donor, and so is her son. Thank you to the four of you for being part of this. I have an opening question, and with a couple of minutes each to answer this question, just to start, before we turn to the policy solutions, I'd like to begin with sort of a diagnostic question for each of you. So in your view, what is working relatively well in the current organ donation and transplantation system, and what is not working well? So where do you see the system's greatest strengths, and where do you see its most serious failures? So in terms of order, let me start with Alex, alphabetically. Let's go this way for this round. Alex.
The starting point of the criticism of the current system that Modify NOTA has given as the justification for the End Kidney Deaths Act is that the system has failed. And I think that is a bad overstatement of the situation. In fact, organ donation over the last 70 years has saved millions of lives around the world, about 500,000 in the United States. And the result has been that has been achieved, the result has been achieved without commercializing the process. There are many faults in the system, and some of them are the disincentives to donation, the financial disincentives to donation, which can be quite directly and easily fixed, and Congress has failed to do so. There are programs, but they are limited by the income of the recipient as well as the donor in ways that make no sense, and they do not cover all expenses. Moreover, the disincentives of the absence of paid leave for recovery after a transplant, a donation of an organ for transplantation, and the discrimination in insurance that donors can face ought to be removed. Moreover, as the National Academy in a report several years ago found, organs are not allocated fairly. And some of this has been a matter of racial and economic discrimination against disadvantaged populations. And so we can make the system much better, but we do not need to make it a system in which organs become paid commodities.
Thank you, Alex. Again, alphabetically, I think, Elaine, you're next.
Thank you, Mario. Some things in transplantation are working extremely well. Overall, the experience for living kidney donors is outstanding. And one of the clearest signs of this is that 95% of surveyed living kidney donors say they would donate again if they could. Well over half of living kidney donors do not spend their own money to donate because lost wages, travel expenses, and caregiver costs are reimbursed through public and private programs. That is real progress. Here is a really important fact. Out of 100 people who step forward wanting to donate a kidney, only about just two actually donate. People with addiction concerns, medical instability, or emotional instability are screened out. Living kidney donors are among the healthiest Americans and actually tend to live longer than the general population. Honestly, in my case, I would donate a kidney every year if it were possible. Nothing feels better than knowing I used a body part I did not need to save someone from an early grave. But what is not working as well? What is not working is that 550,000 Americans are currently suffering on dialysis, and yet only 27,000 people receive kidney transplants every year. Let me give you a quick quote from Dr. Robert Montgomery. In the US, only 10% of people with organ failure ever make it on the waiting list, and once on the list, only 30% ever get an organ. If you do the math, we're actually transplanting only about 3% of the people who could benefit from a transplant every year. It's the most highly rationed thing we do in medicine. Think about this. As Americans, we do not ration insulin, we do not ration chemotherapy because we pay people to produce them. But with kidneys, we expect the supplier to work entirely for free, and every year thousands of Americans die because of that decision. The number of living kidney donors has been about 6,000 every year for 25 years. We've never even reached 7,000 in a single year. And so just picture this for a second. Picture that you yourself have kidney failure and you've joined the transplant waitlist. You are standing in a line of 90,000 people, knowing that half the people in the line will die before receiving a kidney, before reaching the front of that line. Now, numbers are very hard to comprehend, so I just want to share this very real example. This is Lynette Land. Just 5 months ago, she died while waiting for a kidney transplant. If you look at her Facebook page, you can see that she desperately searched for a living donor. Finding a donor is incredibly difficult. My friends, the Collins family, they're a Gold Star family. They lost their son in Iraq, and their surviving child, Joanne, is dying on dialysis. 32 people have stepped forward to donate to her, and none were healthy enough. One day we will look back on this era and wonder why we waited so many decades to end the kidney shortage that kills and harms thousands of Americans each year.
Thank you, Elaine. Thank you very much. Gabriel, the next.
First of all, I want to give, whenever I see an organ donor, a kidney donor, I always give them a hug because it's a wonderful thing to do. So Elaine, I want to give you a big hug, and to your son, I believe, if he was there, I would give him a hug too for being organ donor. I noted that both Elaine and I presume her son donated out of a sense of altruism and not out of payment. And it's been shown in societies across the world, across the globe, that paid organ donation and voluntary organ donation do not exist together. One comes at the expense of the other. I would also say that it is facile to think that we are going to solve the problem of end-stage kidney disease through transplantation. The solution, if there is a solution, will come from prevention. There is such a tsunami of underlying chronic kidney disease in this country that we're not going to solve it through transplanting organs. And as we talk in a positive sense, there have been some tremendous, in the last 5 years, progress in the prevention of chronic kidney disease. And if there's going to be an answer to this problem, it will not be through paying people to be kidney donors. It will be through prevention of end-stage kidney disease, and we are making progress. I should also note that although, as Alex said, the system in the United States is not perfect. I've worked with it for 40 years, and it's damn good. And it's hard to build an edifice. It's easy to put it down. And yes, we have to make improvements, but the system in the United States is really probably better than anywhere else in the world. We should also note here, we're not only dealing with kidney transplantation. We are dealing with heart transplantation, lung transplantation, liver transplantation. So we need more deceased donors. We need more deceased donors because we don't just need kidneys. So if indeed there is a need for improvement, we need to continue to educate the general public that is particularly these days suspicious of organized medicine, to educate the general public towards agreeing to be organ donors in the event of sudden death. So we must promote deceased donation, not only living donation, because we're not only dealing here with kidneys, but we're dealing with other organs too. So I'll talk more about the impact of payments on the workup of donors, because donors are patients, and we need to look at them as human beings and not as pieces of meat.
Thank you, Gabriel. Kim, what's working in the current system and what isn't?
Great. Thank you so much, Mario and Dan, for inviting me to do this. I'm really thrilled to be a part of this panel with these distinguished speakers, all of whom I've had the pleasure of meeting and working with before. So it's great to see everybody. I do think it is important to emphasize that the current system does a lot of things really well. The system rightly treats kidney transplantation as a medical intervention, not an ordinary market exchange. It has elaborate screening, transplant center review, informed consent procedures, allocation rules, and all of these institutional features really matter. They're part of why living donation is ethically defensible at all. What is not working as well is the supply side, and that's a problem, of course, that's not unique to the United States. But as a society, we have built a system in which society asks some people to make extraordinary sacrifices, sometimes for strangers, while insisting that almost any material recognition of that sacrifice is ethically suspect. And that position is increasingly hard to defend descriptively, because many systems already permit donor benefits of various kinds, and also normatively, because the refusal to experiment has life and death consequences. So the system's central failure is not that it refuses to create a crude organ market. And I'd like to kind of shift the discussion away from that during my time today. That's not something that most change advocates, myself included, would support. Instead, to my mind, the failure is that it treats labels like incentive, disincentive, compensation, and payment as meaningful ethical baselines, rather than asking what forms of donor support under which safeguards would improve the system. As Alex mentioned in his opening statement, there's convergence around a notion of making donors whole. And this is something I'll say more about later, but I do not think that making donors whole should mean only reimbursing costs that generate receipts. And in the end, the relevant question is not whether kidney donation should be paid or unpaid or compensated or uncompensated, but what sorts of material recognition are permissible, under what institutional design, and with what protections.
Thank you, Kim, and thank you all for this really great broad overview and introduction of many of the themes that I'm sure we'll discuss in greater detail later. So now, we're going to turn to a specific policy proposal. So I'm going to turn to Elaine. Elaine, you have been advocating for the End Kidney Deaths Act to address the kidney shortage. Could you walk us through the proposal itself? What exactly would it do? What problem is it designed to solve? And why do you believe it's the right policy response in the current to the current situation? For this next segment, you're going to have 5 minutes to describe your proposal, and the other 3 panelists will have 5 minutes each to present their reactions.
Thank you, Mario. The End Kidney Deaths Act is designed to dramatically increase living kidney donation in a structured, regulated, and fully voluntary way. Most Americans support the End Kidney Death Act because they understand this is a practical, regulated, life-saving response to one of the greatest tragedies in American medicine. The legislation builds upon decades of scholarship and research by leading transplant physicians, ethicists, and economists, including Drs. Arthur Macis, Thomas Peters, Sally Sattel, Benjamin Hippen, and economists Alvin Roth, Frank McCormick, and Philip Held. Mario, your own 2019 research also helped inform this work by demonstrating that Americans understand that kidney donation involves substantial time, effort, recovery, and sacrifice, and that compensation for this work is viewed by the majority of surveyed Americans as ethically acceptable. 6 surveys of the American public have demonstrated majority support for compensating kidney donors for their work. 2 surveys of transplant physicians also found majority support for pilot programs involving compensation. The American Medical Association has a policy in favor of living kidney donor compensation. Most recently, a January 2026 University of Chicago NORC survey found that only 12% of Americans oppose the End Kidney Death Act. Only 12%. That is approximately the same percentage of Americans who oppose organ donation itself. The reason for this support is simple. Americans understand that the current system is failing so many people. The End Kidney Death Act is currently a bipartisan bill in Congress with 48 publicly listed House sponsors and an additional 13 members that have committed support but have not yet formally appeared on the list, for a total of 61 congressional supporters. Our team has now held more than 1,000 meetings with congressional offices. So what exactly would the legislation do? The End Kidney Death Act is a 10-year pilot program that would provide a refundable tax credit beginning 1 year after donation of $10,000 per year for 5 years, totaling $50,000 to healthy individuals who donate a kidney to a stranger. These are known as non-directed donors because they are not donating to a specific loved one or acquaintance. They are donating to people they have never met and will likely never meet. The donated kidney would be allocated through the existing national transplant system to patients who have waited the longest for a transplant and who are most likely to die because of the kidney shortage. Importantly, because lower income Americans are approximately 3 times more likely to develop kidney failure, they are also disproportionately represented among those dying on dialysis and on the transplant wait list. The legislation is projected to increase the number of living kidney donors from the current 6,000 annually to approximately 16,000 annually. It could save up to 100,000 American lives over its first decade, while reducing federal spending by up to $40 billion. In the last decade alone, approximately 100,000 Americans died while waiting for a kidney transplant. With this legislation, we will finally have the opportunity to save the next 100,000. When I first became involved in this work back in 2020, I did not fully understand how difficult dialysis truly is. Patients often begin dialysis walking into the clinic independently. Over time, many arrive in wheelchairs and eventually stretchers as their bodies deteriorate. One dialysis patient, Seda Oaks, said something that has deeply affected me. She said, "People ask me what was harder, losing half my body or going on dialysis. I'm not joking when I say losing my legs was nothing compared to living with kidney disease," unquote. By contrast, once patients receive a transplant, many describe it as getting their lives back. One of my friends who spent 5 years on dialysis said to me, "After getting transplanted, I feel as if I was never sick." A kidney transplant is medicine. It simply happens to exist inside another human being. Importantly, transplant centers would continue to determine donor eligibility exactly as they do now. All existing medical and psychosocial protections remain in place, and this legislation is not only life-saving, it is fiscally responsible. Right now, taxpayers spend 1% of all tax money on kidney dialysis treatment for 500,000 Americans, and when somebody moves from dialysis to transplant, the taxpayer saves around $500,000. If that patient no longer relies on disability support and public assistance, the societal savings is $1.5 million. Now, tax credits exist to to encourage socially beneficial behavior. So surely we can provide a tax credit to someone who saves a stranger's life with a kidney donation. The End Kidney Deaths Act offers all of us a realistic opportunity to save tens of thousands of lives while reducing taxpayer spending and dramatically reducing human suffering and needless death. Thank you.
Thank you, Elaine, for describing your proposal. We'll go to reactions next. My proposed order would be Alex, Kim, and Gabriel. But does that work? If so, Alex, please go ahead.
I don't think anyone on this panel would disagree that we need more donors. And the question is not, I think today, for this panel, is not whether there are ethical problems with this, but whether the desire to increase donation will actually be served by this proposal. The advocates of the proposal are people who very much want to use a market-based system, that is to say, a system in which the number of goods available of a particular type of good is affected by the price. And right now, the price paid for a kidney is, as Elaine has suggested, is zero. And so the thought is, applying a classical economic view of supply and demand, if you increase the price, you will increase the supply. The problem here is that we're not dealing with a good that is created. The number of kidneys is not going to be increased by paying. The distribution of kidneys will be changed. But the question is theory here in line with what we know about behavior? And we can see that this is not, as is always claimed by the Modify NOTA coalition, an empirically based proposition. The empirical evidence indicates consistently that when payments are made for organs, both in systems that officially acknowledge that payments can be made, like the Iranian system, and in other examples, when it becomes possible to get an organ by another method, the voluntary donations from living donors dry up. And we have seen this repeatedly. In 1997, for example, when it became possible for patients in Hong Kong who had kidney failure, the amount of donation, the amount of transplants that were handled by living donors was then about 50%. Once China took on the role of taking over Hong Kong again, that dropped to 15%. And many donors who were potential donors, family donors, indicated that they would not give in this situation when a relative could go to China and obtain an organ there through payment. The same thing happened in Israel. Israel had an official system of paying for its patients to go abroad. The insurance companies could pay for them to buy an organ, particularly in the Philippines was a usual destination. Once Israel put an end to that in 2008, their own donation system skyrocketed because people still saw the need for donations, and both living and deceased donations increased. In Iran, the system that the people that Elaine mentioned recently, Ben Hippen, Sally Satel, and Arthur Macis, who had constantly cited Iran as the example of a system with payments, both payments from the government and additional payments from the recipients. as an example of a place with no waiting list. They didn't have a waiting list because they didn't have a waiting list. They did not have the sort of national system we have. And today, the Iranian physicians who run transplant programs have moved away from that because it hasn't worked. The highest rates of donation are in countries like the United States and Spain and elsewhere where there is no payment. Iran is way down the list of donors despite their payments. And we even saw an example of this when about 15 years ago, the liver transplant programs for pediatric patients were changed. And it was permissible to have the donations made from adult deceased donors. And the result of that was that parental donations, which had been the source of living donations to these children, dried up. It turns out that if you have payments, they will crowd out the voluntary donations. And this is going to be a problem if we go to payments. There's no reason to think that in the long run, we will in fact end kidney deaths.
Thank you, Alex. Kim?
Great. I want to focus on three things I like about the proposal, and there are also safeguards I would want to see implemented with the proposal. I'll probably leave the bulk of that for what I gather is a later discussion coming up on safeguards, but I just want to signpost it here. Let me start with what's promising. First of all, it is institutionally mediated, not a private market. And what I mean by that is that the proposal does not create direct bargaining between kidney patients and would-be sellers, unlike some of the other systems that have been mentioned here. It uses the tax system, it applies to non-directed donation, and it operates within the existing transplant apparatus. All of that really matters because many objections to organ markets are really objections to bilateral bargaining. Sorry, I can't speak today, to desperate sellers, to price competition, and to unequal patient access. So I would distinguish sharply between a state-administered donor benefit, which is what this is, and a private market in kidneys. The former may still raise some hard questions, but it does not raise the same questions as a buyer and seller negotiating over an organ. The second thing I like about the proposal is that it focuses attention on institutional design rather than symbolic labels, and it forces us to consider whether quote unquote reimbursement only really makes donors whole. As I've already said, in my view, it does not. So I would evaluate the proposal not by asking whether it crosses some metaphysical line between reimbursement and incentive or payment or non-payment, but by asking whether it is well designed. A refundable tax credit is money, but it's not the same institutional form as a cash sale to a recipient. So I think the better questions are what follows from that. Who provides the benefit? Who receives it? How is it timed? How are donors screened? And whether access to kidneys remained governed by medical need rather than by purchasing power. Now, I agree that removing disincentives to donation is important, but I want to emphasize that I do not think we should define disincentives only as receipts, mileage, hotel rooms, and lost wages. Kidney donation imposes real costs that do not appear on a receipt. Surgical risk, pain, recovery time, disruption to family life, anxiety, lost leisure, and the burdens of medical testing and follow-up. So if we say that donors may be reimbursed only for out-of-pocket expenses, then we're not, in fact, making them whole. We're making them whole only for the subset of costs that are the easiest to document. And that is not a neutral ethical line. It privileges certain kinds of losses over others. Lost wage reimbursement is a good example. It compensates people who work for wages outside the home, but it doesn't compensate people whose time is valuable in other ways. Caregivers, students, retirees, people doing unpaid household labor, or people with flexible but demanding work. So a narrow reimbursement model can look ethically modest while actually reproducing inequalities in what losses we think count. So in my view, the End Kidney Deaths Act does make donors whole. And the reason it does that is because donor costs are not limited to financial expenditures. If a person undergoes surgery for the benefit of a stranger, the relevant burdens include more than the amount that they paid for parking, childcare, or a hotel room. And we routinely recognize in other contexts that pain, risk, time, and inconvenience are compensable harms. It's not obvious why kidney donors should be the one group for whom those burdens are treated as morally invisible. Finally, it's structured as a pilot, which makes empirical evaluation possible. So if we're going to debate this as a pilot, then we should take the pilot idea seriously. That means specifying in advance what we want to know: effects on donation rates, donor demographics, donor understanding, long-term donor welfare, public trust, and the distributional consequences for recipients. That brings me to the things I'd like to examine further, but I'm going to leave those to our safeguards discussion.
Great. Thank you so much, Kim. Gabriel.
Yeah, I'm going to play the doctor role because I've spent a lifetime with promoting kidney transplantation, organ transplantation, and working with recipients and donors. Kidney donors are patients, and we need to evaluate the process, the kidney donation, in the same way as we evaluate any risky process. Risk against benefit. What is the benefit for a kidney donor, an altruistic kidney donor? Studies have shown over and over, and we can see this by the joy on Elaine's face. The kidney donation makes people, altruistic kidney donation makes people feel very well about themselves. So that the risk that they've gone through is balanced by the gain in their sense of self-worth. But time and again, it's been shown that people who donate because there's a financial benefit do not get that gain. They do not get that gain. It's been shown in Iran. It's been shown in other places too that there actually is that there is an impact on self-worth and an impact on depression, and of people who donate because of financial reasons, as opposed to people like Elaine and her son who've donated out of altruism and out of love. There's another important point. The process of evaluating a kidney donor is not a thumbs up and thumbs down. It is a highly nuanced medical procedure with risks and benefits, highly nuanced. We are dealing with patients who are older, patients who may have borderline diabetes, patients who have borderline hypertension, and that if you were ever to attend the meetings where we discuss these things, the decision about whether to move ahead with a donation is a very refined one, and it must not be distorted by payment. The thought that, well, someone has borderline diabetes and someone has borderline hypertension, but you know what? They're going to get $50,000. That must not distort the process, and money will distort that evaluation process. And I'm concerned that donors who donate, when part of the reason why they're doing it is payment, are going to end up losing the benefit that they will get from it, the benefit that we can see in Elaine's face. And I want to say something else about the term modifying NOTA. This particular proposal, which may sound quite benign, the way that Dr. Krawiec just presented it, is actually a wedge issue. It's an issue that opens up NOTA, the National Organ Transplant Act. It opens up, and you're opening up a Pandora's box. Because once that box is open, not just in the United States, but throughout the world, where the US system has been an example, we are asking for trouble. We are asking for payment models, not just this one that sounds fairly benign, but payment models that become much more dangerous, developed once we open up NOTA. And I'm very concerned, not just about the national impact of opening up NOTA, but the international impact of opening up NOTA, where we're likely to see payment models, because the US has done it, why should we do it, introduced across the world, will have major negative impact on exploitation of poor donors. Although this system sounds benign, modifying NOTA, opening up NOTA, to my mind, is really very, very dangerous and has the likelihood of undermining the whole ethical building of our current transplant process, and will not get the numbers that have been suggested. As Alex has suggested, paid donation comes at the expense of unpaid donation. We must not go there. We have to promote more deceased donation, and we have to remove disincentives to donation, which is something all of us agree on.
Thank you. Thank you very much to all for this really excellent round of comments. You've laid out many, arguments, and I really appreciate that depth of the conversation. So for the next round, I would like to give Elaine an opportunity to respond to the comments that were made. Particularly, Elaine, I'd like you to tell us, how you would respond. You would like to respond to the criticism and the concerns that have been raised in particular. And next, we've decided that 3.5 minutes each for this next round. So Elaine, you respond to the comments, and Gabe, Kim, and Alex will have another opportunity to express additional comments after you, Elaine.
Thank you, Mario. So I just want to first of all say that the National Kidney Donation Organization ran a poll, and only 2% of kidney donors stated that they were opposed to the End Kidney Deaths Act. Also, as Gabe noted, the kidney shortage is a global shortage, and once the legislation passes here, we will support countries around the world to pass similar legislation. So I was speaking with Dr. Mohammed Hani Hafez, the leader of the transplant program in Cairo, and he said to me, we need the End Kidney Deaths Act in Egypt. Throughout the world, millions of people are suffering from the global kidney shortage, and the End Kidney Deaths Act will put everyone on the pathway to finally ending the era of these premature and preventable deaths. They will no longer continue. Also want to mention that the End Kidney Deaths Act is fully consistent with 4 major principles of medical bioethics. For example, beneficence. It upholds beneficence because it helps people receive life-saving transplants. It also supports non-maleficence because all of the current donor protections will remain in place. It supports autonomy because it respects the right of informed, healthy adults to make voluntary decisions about their own body. And finally, the 4th principle of justice. This proposal supports justice because the current shortage disproportionately harms lower-income Americans who are much more likely to develop kidney failure and much less likely to find living donors. Now, for the past 6 years, since I donated my kidney to a stranger back in 2020, I've spent an enormous part of my life trying to increase the number of kidney transplants in this country. I stand on New York City streets and subway platforms wearing a sandwich board that says, donated my kidney to a stranger and you can too. I've worked with the National Kidney Foundation and the National Kidney Donation Organization to increase living donation. I've also worked to pass 2 laws, the New York State Living Donor Support Act, and most recently the Federal Honor our Living Donors Act. Both bills, I'm very proud to say, passed unanimously, and both remove financial barriers for donors. But despite all of the donor protections, public education, outreach, roughly 10,000 Americans continue to die every year while waiting for a kidney transplant because nowhere else, as Kim said in medicine, do we expect people to perform difficult life-saving work entirely for free. To be a living donor, you have to be super motivated, you've got to be brave, and you have to be deeply caring, devoted to going through the months of testing, surgery, and recovery to save the life of somebody you've never even met and likely will never even meet. And I want to make it clear that the status quo is not ethically neutral. Thousands of people dying every year from a solvable shortage. That's not a neutral outcome. It's a lousy policy choice. Now, as we know, people on dialysis are suffering as we speak, but when they get a transplant, color returns to their faces, their energy returns, their hope returns. They can go back to falling in love, they can become parents, they can go back to work. Some even participate in, they sort of have an Olympics called the Transplant Games of America for donors and recipients. That's the difference a transplant makes. This is not an abstract ethical theory. This is about actual human beings who are dying while we are giving these presentations. Now, I think we have to have this urgency to end this era. Prevention will not save the people who are dying right now, though I'm all for prevention. I just want to mention my son, AB's recipient, Chris, who received his kidney transplant, 21 years old. His skin was gray. His father told me he was dying. And after receiving the transplant, he finished high school, graduated from college. He's a new father, and he hopes to attend medical school. Transplantation gives people their life back, and I want every person currently waiting for a kidney transplant to have that same opportunity to return to a full life. This is a common sense no-brainer, and please help us pass the End Kidney Deaths Act so we can begin this 10-year pilot program to put us on the pathway to finally end the era of people needlessly suffering and dying while waiting for a kidney transplant. Thank you for the opportunity to share my thoughts.
Thank you, Elaine. Thank you. Alex, Gabriel, Kim, how would you react to Elaine's reaction?
I love Gabriel. I love Elaine's enthusiasm. I love her enthusiasm. But I suspect that had she donated not out of love and caring, but because there was a financial gain, she would not be quite so enthusiastic. I've used the term Trojan horse to describe this kind of legislation because it looks so attractive. It looks so easy. It looks such we're going to solve everything. But it's not, because once you allow that Trojan horse to open up NOTA, we are opening up a Pandora's box of problems that will actually undermine the system we have in place. And will not strengthen it. I just do not accept many of the numbers that Elaine has mentioned today. I really do believe that the thought you're going to end kidney death with this proposal is, with all due respect to you, Elaine, and your supporters, is facile. I think we may, in fact, do the reverse, and we must continue to promote altruistic living donation, remove all the disincentives to donation, incentivize through education, incentivize through public trust, promote deceased donation so that we can get more hearts and livers, etc. But introducing this Trojan horse into the current system, nationally and internationally, I think would be a disaster.
Abe, Alex or Kim, who wants to?
Kim, why don't you go?
Sure. Is this where you wanted us also to discuss whether there's common ground here, Mario?
Yes, ideally, yes. I would like to explore that possibility.
Okay, great. So I guess I'm going to start with emphasizing what I think there may be some common ground, right? I do see common ground with at least some critics of the proposal, because almost everyone in this debate cares really about four things: increasing transplantation, protecting donors, preserving equitable access for recipients, and maintaining public trust. And so by focusing on those four things, I think we can find some common ground. I would also separate two kinds of objections. One is a categorical objection that any material benefit for kidney donation is inherently impermissible. I don't find that persuasive, and I feel like Gabriel's objections are sort of near that point. And if that's the case, then the safeguards won't matter, and there's actually very little common ground. I don't think that is everyone's objection. The other objection is more of what I consider to be an institutional design objection, that a particular system can produce exploitation, misinformation, inequitable access, or loss of trust. And those objections are serious. I don't intend to minimize them in any way, but they are not arguments against experimentation. They are arguments for designing the experiment very carefully and learning from it, and I think create a common ground to work towards solutions. So the design features I would look for, I've mentioned no recipient to donor payment, no bargaining between patients and donors, allocation by medical criteria rather than wealth, independent donor advocates, full disclosure that this is a serious surgery. We already have some of these things embedded in the system, obviously. Coverage for long-term donor follow-up, transparent reporting on donor demographics and outcomes, and a sunset provision requiring evaluation before expansion, because again, this is a pilot program. It's designed to gather information, some of the very information that critics have said we're lacking. So I'll stop there and let Alex say his piece.
There are three comments. The first is that the irony is that this is classical economics that makes this what Elaine calls a no-brainer. The idea that if you pay for something, you'll get more of it. Behavioral economics suggests otherwise. And we have had a natural experiment around the world, and that is not just limited to transplantation. There are other examples where the phenomenon of crowding out an activity that was voluntary and unpaid by an activity that was paid. The second thing is, why $50,000? That is not the way we usually get to an appropriate amount to pay. That we haven't had a market, so we don't know. Modify NOTA for originally proposed $100,000. Then about 3 years ago, when they were going to Congress to get the bill started, they changed with no explanation. Why should it be 50,000? Gary Becker, the Nobel laureate, once suggested $15,000 was appropriate because of the effort and risk involved. We can take care of risk, Kim, by insurance that would be against future losses, instead of giving everybody, most of whom would not suffer those losses, a fixed amount at the beginning. Why is $50,000 appropriate? It's a totally arbitrary number. And people like Frank McCormick, whom you cited, Elaine, have already said, if that amount doesn't work, we'll increase it. Why only pay non-directed donors? Once we're paying, why aren't we paying the directed donors as well? All the rules that are being set up, the notion that we're going to set safeguards on this, why do we have to do anything special by way of safeguards rather than having the system that we already have that is medically oriented? Well, if you're saying that the ultimate good is having a transplant recipient get an organ, we're in effect saying anything that limits that is in fact impermissible. And so if we have to pay more, if we have to pay different amounts, not every patient is going to benefit just from the random people who happen to decide that they need $50,000. If, for example, in minority communities, donation rates are lower, and yet those donors are needed for minority patients to receive an appropriate transplant, what if we then end up having to say, well, some populations have to be paying more? that should be permissible too. If I want to buy an organ from someone, that is to say, I want to go outside the system and pay more, what's wrong with that? On its face, it takes a patient off the waiting list. Everybody else moves up. Once we've said payments are all right, we're not saying categorically paying for organs as though they were a commodity is wrong. And if we do a 10-year experiment and it doesn't produce what Elaine and the other supporters want, it produces what Dr. Danovitch and I are afraid will happen based on empirical experience and the natural experiments we already have, all of which show that. Can we possibly think of going back to a system where we don't pay for organs? We will have destroyed the transplant system of voluntary donations, and the numbers of people who will need a transplant will rise as a result. A number of people on the waiting list will rise as a result.
Thank you, Alex. Oh, thank you all. This was an incredibly informative conversation, and you gave us and our audience really a lot to think about. And I at the same time, I feel that we could continue for another hour easily, but we only have a few minutes left, and I did promise that we would give our audience a chance to ask questions. Now, we have many very good questions from the audience, and so in the interest of time, I've sort of combined them into a few of them into some sort of broad questions. So one of them that interests me actually personally, having done survey work on this subject, is this, and this is a question that goes to all of you. How much weight should public opinion carry in a debate like this? If a certain policy seems to enjoy public support, how much does that matter, like morally, or are the ethical questions here fundamentally independent of what the public happens to think? I'm curious what your thoughts are.
I think public opinion is in favor of the End Kidney Deaths Act and compensating donors, and I think it's incredibly important because by following public opinion, we will also maintain trust.
The question is, what does the public think about the act when it is presented as something which is a no-brainer, that it obviously will increase the level of donation? And there's every reason to think that that is an inaccurate statement. And if we have the act enacted, we will not be able to unenact it. Once we start paying for donation, the number of people who will think it's appropriate to give an organ will decrease. And if you don't pay after that, if you say, well, it didn't work, so we got to go back to no donation, turns out it was harmful, it will be impossible to find donors.
Yeah, I absolutely agree with Alex. How you survey the public depends on the question you ask them. We should be in the business of educating, not surveying the public, but educating the public on the importance of deceased donation, of signing their donor cards, of turning to family members if in need as potential kidney donors, for teaching the general public about organ donation, both deceased and living, and not surveying them in the absence of the broad medical issues that are associated with organ donation.
I would say that public opinion matters in this setting because public trust in the transplant system is important. It's been under stress, shall we say, during the past year, if not more. But in my view, doesn't tell us much about what is ethical and what isn't. And so to me, it's not important for that reason. But it is important to not deviate too far from what the public views is fair.
Thank you. Thank you so much. There were many other questions from our audience, but we are at time. Thanks to our audience. And again, thanks to our panelists for a very informative conversation. Even as someone who has worked on these issues, I truly learned a lot. And I'm very, very grateful. Elaine, Gabriel, Kim, Alex, thank you.
Thank you, everyone.
Mario. It was great.
Thank you.
Thank you.